Good morning. I'm Dr. Jeffrey Hayes, Education Specialist for the American Society for Reproductive Medicine. Welcome to the latest presentation of the ASRM Grand Rounds webinar series. These webinars are designed to address topics in the ABOG Guide to Learning in Reproductive Endocrinology and Infertility. Today's presentation will be given by Dr. Judy E. Stern. Dr. Stern is currently Professor of Obstetrics and Gynecology and Pathology at Dartmouth-Hitchcock in Lebanon, New Hampshire. The title of her talk today is Perinatal Outcomes of Assisted Reproductive Technology, Influence of Treatment and Diagnoses. I will now review the details of today's presentation. After the webinar is done, please do not forget to return to ASRM eLearn to take the post-test and complete the survey for your continuing education credits. You must complete the post-test questions successfully and complete the survey to receive credit and be able to print off your certificate. If you wish to ask a question to the speaker about this presentation, when you return to ASRM eLearn, click on the page link labeled Questions, and an ASRM email address will be provided for you to send your question into. After the time period for questions has expired, the questions page will be a frequently asked questions page pertaining to this presentation and topic. Our speaker today is Dr. Judy Stern. We're very excited for her talk, so I'll now turn things over to Dr. Stern.
Thank you, Dr. Hayes. Hello and welcome to the webinar, Perinatal Outcomes of Assisted Reproductive Technology, Influence of Treatment and Diagnosis. I have no conflicts of interest. The learning objectives for this module are to define the perinatal risks associated with ART treatment, review the ART treatment parameters that most affect these perinatal risks, and evaluate whether underlying subfertility and infertility-related diagnoses influence ART outcomes. ART has been practiced for almost 40 years. The first birth from ART, which includes IVF and related technologies, was that of Louise Brown, who was born in July of 1978. The Jones Institute, the first to perform this procedure in the US, opened for business in 1980. Use of ART has increased dramatically over its 40 years of practice. As seen in the graph, in the US alone, number of cycles has increased to over 170,000 per year, and the number of babies to over 55,000 per year. There have been more than 5 million births to IVF worldwide. ART has now become standard of care for the treatment of infertility. So it's hard to remember that the introduction of this technique was not without controversy. Prior to introduction of ART, many people worried that children born from this technique would be abnormal. In 1974, for example, an ethicist by the name of Leon Kass wrote the following about IVF in the New England Journal of Medicine. Serious questions can be raised about the safety of the manipulations, and hence about the normality of any child whose conception and early development were subject to such manipulation. He went on to say, the moral question is this: does the parent's desire for a child entitle them to have it by methods that deliberately impose upon that child an unknown and untested risk of deformity or malformation? Well, as we now know, Louise Brown was a normal, healthy baby, as have been the vast majority of babies born from ART. However, ART success rates were initially very low as less than 5% per cycle. And to boost this percentage, practitioners introduced the use of gonadotropin administration to stimulate the production of multiple oocytes. Transfer of the multiple embryos resulting from these oocytes increased success rates. However, it also resulted in a high proportion of multiple pregnancies. A paper by Jane et al. In 2004 shows the increasing trends in the US multiple rates from the early 1980s. And this is twins and triplets and higher order multiples. A 2013 paper by Kulkarni et al. Demonstrated that while some of these multiple gestations come from other assisted conception methods, so these are non-IVF twins, non-IVF higher order multiples, many of them still come from IVF treatment. That's twins and higher order multiples. Recent decreases in embryo transfer number have resulted in decreasing rates of higher order multiples, but not yet much change in twin rates. Increased use of single embryo transfer may soon change that. We need to remember that multiple pregnancy itself is not without risk. These numbers from a study by Luke and Brown in 2007 using national U.S. data demonstrate this, and this is U.S. data, not ART data specific. Using Singleton delivery as the reference, the data show that pregnancy hypertension increases in twins and triplets as compared to singletons, as does premature rupture of membranes, and premature delivery at less than 29 weeks is 8 times more prevalent in twins than singletons and 32 times more prevalent in higher order multiples. Infant death is 4 times higher in twins than singletons and 13 times more common after triplets or higher order deliveries. This is why ASRM practice guidelines now define successive ART as a singleton pregnancy that results in a healthy singleton infant born at term. So we know that ART increases multiple birth and that multiple birth can compromise health of babies. But what about singletons? For a long time, we assumed that singleton ART babies had the same perinatal risks as singleton babies from spontaneous conception. However, in 2002, 2 articles came out in the New England Journal of Medicine that caused us to rethink this assumption. The first was an article from the U.S. written by Sheev and co-investigators at the Centers for Disease Control and Prevention. This article found that while much of the higher rate of low birth weight babies from ART could indeed be attributable to multiple gestation, there were also higher rates of low birth weight among singleton infants conceived with this technology. The second article was from Australia and found that ART with or without ICSI, intracytoplasmic sperm injection, had a higher rate of major birth defects than spontaneously conceived infants. A subsequent paper in 2004 by Sheev and co-investigators gave numbers for birth weight and prematurity as shown in this table. The comparison group for this study was national U.S. data, also shown in the table. So the national U.S. data are here. ART in 1996 and 2000 are shown here. While the overall percentage of low and very low birth weight is still not particularly high, the percentage in both 1996 and 2000 was significantly higher than that in the general population. So low birth weight compared to U.S. rates, very low birth weight compared to U.S. birth weights. And preterm birth was also elevated. At this point, I'd like to mention something about the data used for the U.S. analysis from the CDC. The data come from the National ART Database, which at the time of this study was collected jointly by the CDC and the Society for Assisted Reproductive Technology, or SART. Data are collected under a 1992 law, the Fertility Clinic Success Rate and Certification Act. All U.S. clinics are required to report all U.S. ART cycles under this law. There are currently 2 parallel versions of this national data collection, that maintained by SART and a separate collection maintained by CDC, although the SART data are fed to the CDC system. I'll come back to the use of these data later in this webinar. With the understanding developing that ART singletons had a higher rate of premature birth and low birth weight babies than spontaneous pregnancies, investigators began to wonder what aspects of ART treatment might contribute to these risks. Candidates for initial consideration included the in vitro culture itself, that is to say, all manipulations of eggs and embryos in vitro, and the fact that these are maintained in culture outside of the body. Intracytoplasmic sperm injection, or ICSI, about which concerns had been raised regarding the injection of the sperm into the egg as bypassing normal physiology. Cryopreservation, which involves that the embryos be subjected to both the cryoprotectant chemicals and extreme cold, as well as extended periods of storage. and the continued transfer of multiple embryos. Now, there's extensive literature on each of these possibilities, any of which could probably be a full webinar in itself. Nevertheless, what I'll do here is to review a few studies on each of these possibilities to make the point of what happens as a result of them. Data on this slide come from a meta-analysis of studies on ART outcome that had accumulated through 2009. The preponderance of evidence indicates that IVF, including ART cycles here with standard insemination, and I'm going to use IVF to mean ART with standard insemination for the rest of the webinar. Even in singletons, and these are singletons, does result in an increase in both prematurity and low birth weight. So preterm birth here had a relative risk of 1.84, and low birth weight a relative risk of 1.6 compared to spontaneous conception overall. Time and in vitro culture has also been implicated in increasing perinatal risk. In this 2010 study, for example, blastocyst culture increased preterm birth and risk of malformation in singletons when compared to cleavage stage transfer. Whether this observation will hold up with additional study remains to be seen, but it suggests that time in culture could indeed have an effect on outcome. Turning to ICSI, a 2012 meta-analysis by Pandy et al. Evaluated the influence of IVF ICSI as compared with spontaneous conception on outcome. As seen in the table, ICSI deliveries had a higher rate of low birth weight and very low birth weight, as well as a higher rate of prematurity. So, spontaneous conceptions as the reference, and then this is ICSI. This is low birth weight and very low birth weight, and prematurity, gestational age under 37 weeks and under 32 weeks. The pregnancies themselves had higher rates of gestational diabetes, as well as pregnancy hypertension and premature rupture of membranes. I'm showing only gestational diabetes here. In addition, the rates of congenital anomalies were also reportedly higher in the ICSI group. A study in 2013 looked more closely at aspects of ICSI treatment by separating cases with ejaculated sperm from those with aspirated or biopsied sperm, as well as having, in this case, a non-ICSI or IVF insemination comparison group. Mean birth weight did not differ between groups in singleton firstborn deliveries, but adjusted odds of low birth weight were higher for the aspiration biopsy group than spontaneous conceptions or controls. And here the reference group is the aspiration biopsy group, and this is the spontaneous group with a lower rate. Unfortunately, since the aspiration biopsy group was the reference group in this study, it did not also show the direct comparisons of the other groups with spontaneous conceptions. You really can't see whether these are different, but they didn't differ from the aspiration biopsy group. This is the ejaculated sperm with ICSI, and this is the insemination group. Adjusted odds for gestational age did not differ in the groups, but cardiac malformations were 3.6% for the aspiration biopsy group, significantly greater than for the IVF group at 1.4%, or the spontaneous controls at 1.1%. More severe malfactor had higher rates of cardiac malformations in singleton boys and higher rates of undescended testicles for singletons as well as twin boys. This increase for ICSI has been seen in a number of studies. However, the contribution of the procedure itself, as compared to that of the underlying male infertility, is still to be determined. In summary, the data showed only minor difference in aspiration biopsy with standard ICSI and IVF, but it did show a difference with spontaneous conception. Turning to frozen embryo transfer, studies have suggested fewer risks with the frozen than with the fresh embryo transfer. Birth weight in a 2010 study was higher in the cryopreservation cycles than the fresh by 204 grams, and length of gestation was longer by 2.4 days. The risk of low birth weight and preterm birth in adjusted models was lower in the cryopreservation cycles. Of note, even though the frozen did better than the fresh transfers, they also still did less well than the spontaneous conceptions. This trend was again seen in a Nordic study by Wennerholm and colleagues, in which frozen embryo transfer had a lower risk of low birth weight, preterm and very preterm birth, and small for gestational age babies than fresh transfers. In this graph, developed from the data presented in the study, the adjusted odds ratio is on the y-axis, and the red line shows an adjusted odds ratio of 1. Frozen as compared with fresh transfers is shown in blue. So this is frozen compared to fresh. These show, again, the lower risk of low birth weight, preterm and very preterm delivery, and small for gestational age. Seen in orange is the higher rate of these outcomes when compared with spontaneous conceptions. So even though the frozen embryo transfer had lower rates than the fresh, the frozen still, again, had higher than the spontaneous conceptions. However, this study additionally showed a somewhat concerning observation that large for gestation babies and macrosomia, or abnormally large body size, were also increased in frozen as compared with both fresh transfers and spontaneous conceptions. So here, both the frozen versus fresh and the frozen versus spontaneous are higher. Perinatal mortality was also increased for the frozen embryo transfer cycles. In this case, these risks were increased both in relation to the fresh, again, and the spontaneous conceptions. A 2016 study by Corsi showed similar results, that frozen embryo transfer had a higher percentage of large for gestation babies than spontaneous controls, while fresh transfer did not result in this increase. Reasons for this difference are not yet known, including whether the results seen with frozen transfer are influenced by patient selection for freezing or other factors unrelated to the procedures themselves. But they do suggest caution when turning to practice patterns that preferentially increase the use of frozen embryo transfer over fresh embryo transfer. We don't know exactly what the effect of large for gestation babies is, but it is generally associated with an increase in metabolic disorders in children. Whether this is true for ART pregnancies also remains to be studied. We've been talking thus far primarily about singletons. Of note, however, is that when twins are evaluated, the risks for twins have generally not been shown to be higher for ART than for spontaneous conceptions, as was shown in this 2008 study from the CDC. In fact, the risks with ART may have been lower in ART births in that study. And here, the contribution of monozygosity, the rate of which is probably higher in the spontaneous conceptions than in the ART conceptions, which are generally dizygotic, is not known. This is another aspect that has to be sorted out. Also, with regard to ART singletons, it's important to remember that while the number of embryos transferred has been declining over time in all age groups, the majority of transfers still involve transfer of more than one embryo. So this is the decline over time. This is a study that just came out by Toner et al. On the SART data. And this is the number of single embryo transfers. For example, in women under 35, the most likely group to receive single embryo transfer No more than about 30% of transfers are singles. So there's still a high rate of multiple transfer in most groups. Exploring this further, a European group in 2007 suggested that transfer of multiple embryos can result in more than one implantation site, even when a singleton pregnancy results, and that loss of these additional sites may result in singleton deliveries with lower birth weight and an increased rate of small for gestation babies. In 2009, we reported on this phenomenon in a U.S. population from the National SART Corps database. We found that when compared with having one fetal heart on early ultrasound, the risk of preterm birth and reduced birth weight was increased when either 2 or 3 fetal hearts were seen in early pregnancy. So this is one fetal heart as the reference. This is 2, and this is 3 or more. And remember, all of these deliveries are singleton deliveries. So these fetal hearts were early in pregnancy, but the birth then still resulted in a singleton. So each of the preterm birth and lower birth weight groups had a higher adjusted odds ratio, while the term and normal birth weight groups had lower adjusted odds. So we've reviewed some of the treatment factors that contribute to adverse outcomes from ART. However, it must be recognized that even with single embryo transfer of IVF cleavage stage embryos, that is inseminated cleavage stage embryos, the perinatal outcomes of ART appear to be compromised. Other contributory factors must be considered. And some of these may be related directly to the patient population who undergo ART. Now, we know that in all populations, age, BMI, or basal metabolic index, prenatal care, and other factors such as diet and socioeconomic status contribute to outcome issues. While many of these factors are adjusted for in studies of ART outcome, it's important to recognize that with regard to age, women undergoing ART tend to be older, and that age plays a part in outcome. But there are other factors that could contribute to ART outcomes, and these include underlying disease, chronic health issues in women, and potentially the infertility itself that led to the use of ART to begin with. Just to mention age quickly, this 2007 study by Luke and Brown demonstrates the effect of age. Now again, this is using a U.S. population. These are not ART deliveries, but it does show the effect of age. The authors demonstrated that as age increases, underlying chronic hypertension increases. So these are your increasing age groups. Pregnancy-associated hypertension increases, and premature delivery increases, as well as the rate of infant death. Trying to get to underlying issues that contribute to ART outcome, a clever study in 2008 by Romstead et al. Pointed to a role for health issues in the women undergoing ART. This study looked at sequential deliveries to the same woman, one spontaneous pregnancy and one ART-conceived pregnancy. As in other studies, when the ART pregnancies as a group were compared with the spontaneous pregnancies, there was a higher rate of preterm delivery, low birth weight, and small for gestational age babies in the ART deliveries. However, when the data were compared within women, that is to say, from one pregnancy to the next within the same woman, using her as her own control, the difference was far less pronounced. 9 grams of weight versus 25 grams overall in weight, and 0.6 days versus 2 days in gestational age. The authors concluded that much of the observed adverse outcome with ART might be explained by attribution to the underlying infertility. So while they still saw some difference with ART, that difference was far less pronounced. Before I go on, I want to mention two issues of importance in ART outcome research, one of which you may be aware of from studies presented so far, is that many of the studies have been done in countries other than the US. While this research is obviously extremely valuable, there's more ART performed in the US than in many of these other countries. And yet the US is underrepresented in the research. A good example of this underrepresentation is found by looking at the countries from which studies included in a meta-analysis by Hansen et al. On congenital malformations in 2014 was done. In this study, only 4.3% of studies reported on were from the US or Canada, whereas most of the others were from Europe or Australia, 73.5% from Europe, many of those Scandinavian countries, and 16.5% from Australia. There are many reasons for this, not the least of which is that we have virtually no comprehensive medical databases for outcome data in the US. We have the SART-CORS data for ART information, but the subsequent outcome data and pregnancy data and long-term health data are not part of that database. If collected at all, very often these data are collected at the state level in the US, making US data very inaccessible to research. The other issue for ART research is that most studies have used spontaneous conception as the control group. And this means that if underlying infertility contributes to adverse ART outcomes, then we'll not have a means of measuring this in these studies because the control group that we're using is spontaneous conceptions. So we have to look for a control group that might be better. Subfertile patients, patients who've used intrauterine insemination, or another group that would be a more appropriate control for the ART pregnancies. To address some of these issues, we embarked about 10 years ago on a project to study ART outcome in the state of Massachusetts. And again, while there are a number of other studies using subfertile groups or IUI as controls, I'm going to move forward here and talk mainly about these studies that we did using this Massachusetts data. In Massachusetts, vital records data for deliveries, hospitalizations, birth defects, and other critical outcome measures were already linked by an ongoing research project within the state vital record systems. So we decided to link the SART-CORS national ART data with this linked system called the Pregnancy to Early Life Longitudinal, or PEL data system. And in that system, we have vital records data, newborn screening, birth defects registry, mother and child deaths, pregnancy-associated information, all of the birth certificate data, and hospitalization and discharge, discharge information. Although a limitation of these analyses is that, again, they represent only a single state. There are actually more ART deliveries in this state than in many of the countries, such as the Scandinavian countries, for which data systems have been used in a lot of the prior ART research. Once we linked these databases, we then defined a subfertile comparison group. We defined this group on the basis of 3 criteria: a checkbox on the birth certificate showing deliveries that had some kind of fertility treatment, although the birth certificate did not clearly show which was fertility treatment by ART and which was not. That we found by whether or not the cycles linked to SART-CORS. If they did, we included them as ART deliveries and not subfertile deliveries. Deliveries with prior ART identified in SART cores, in other words, an index delivery to a woman who had a prior ART cycle, or hospitalization with an ICD code for infertility within the 5 years prior to the index delivery. And we compared this subfertile group to ART deliveries and to a fertile group, which included women who were in neither the ART nor the subfertile group. We found that while ART had higher rates of preterm delivery and low birth weight deliveries than the fertile group, and this is preterm delivery, low birth weight, small for gestational age, and perinatal death. Fertile group is the reference control, and this is the ART group, higher rates of preterm delivery and low birth weight. The rates in this, there was no difference in small for gestational age babies. But the ART group was also somewhat different from the subfertile group, only the magnitude of that difference was not as great. Perinatal death was elevated in the subfertile group, but not the ART group, a finding that we have not yet explained. In addition, using this system, we could look at pregnancy-related issues and found that gestational diabetes and pregnancy-related hypertension also differed between the ART, subfertile, and fertile groups. I'm just showing the gestational diabetes here. I should mention, too, that we've seen the same patterns for birth defects, a finding that we're currently preparing for publication, and that pattern being that the ART is higher than the subfertile, which is higher than the fertile. In order to drill down a little further into possible effects of infertility, we then directly evaluated the effect of underlying diagnosis on outcomes within the ART population. So this is only ART deliveries that I'm going to show you in this study. The diagnoses here were determined from SART cores and compared using male factor as the control group, as the reference population. And we had endometriosis, tubal, ovulatory disorder, uterine, diminished ovarian reserve, and other. We found preterm delivery to be elevated in patients with ovulatory disorders and other diagnoses as the only significant infant outcomes. But interestingly, we also found that pregnancy hypertension, gestational diabetes, and prenatal admissions to the hospital were differentially expressed in women with these different diagnoses compared to the male factor patients. To extend these studies further and compare different diagnoses to a group of fertile deliveries, we identified women in the ART group by infertility diagnosis, but also identified a group of deliveries to women who had been hospitalized for an infertility-related diagnosis, but whose delivery did not link to an ART delivery. So we have our fertile group here. We have an ART group identified through SART cores, and we have a group with no ART, so these were not SART cores patients, but these were deliveries in which an ICD-9 code in the hospitalization files linked to one of these three diagnoses. The ART group had male factor, endometriosis, ovulatory disorder, and tubal disease. The non-ART group, we had endometriosis, ovulatory disorder, and women who'd been hospitalized with reports of reproductive tract inflammation, including pelvic, tubal, and uterine inflammation. We compared these groups, realizing the limitation that the non-ART group, having been identified through hospitalization, may have had more severe diagnoses than the ART group, where hospitalization for infertility-related diagnoses itself had not occurred. With the exception of endometriosis patients treated with ART, all groups had elevated risk of preterm delivery and low birth weight when compared with the fertile group. The reproductive tract inflammation group also had a higher rate for small for gestational age babies. So all these groups, so this is ART, no ART obviously in the fertile group. Male factor was an ART group and had higher rates of preterm birth and low birth weight. Endometriosis, yes and no. The yes group did not have a significant increase in preterm birth, but the no group, the group that did not have ART, did. Ovulatory disorders, both of these had increased rates of preterm birth and low birth weight. Tubal, again with ART, and the inflammation group. This graphic shows the adjusted odds ratios for maternal outcomes, prenatal hospitalizations, and cesarean delivery in the study population. Adjusted odds ratios are again seen on the y-axis with an odds ratio of 1 shown here with the red line. And again, the fertile population is the reference group. The fertile population is shown in blue. When we looked at pregnancy hypertension, gestational diabetes, and prenatal outcomes, diagnosis, even in the absence of ART treatment, had a significant effect on a number of these parameters. And remember that some of these diagnostic groups may have been more severe diagnosis than the ones in the ART population, which may be why we're seeing more emergency room visits or observational stays in some of them. We should note that all of these groups had higher rates of cesarean delivery, except for the inflammation group. For hospital admissions, all diagnoses, again, other than male factor, both with and without ART treatment, had elevated risks. Regarding gestational diabetes, risks were elevated for patients with ovulatory disorders regardless of ART treatment. So the data strongly suggest that the diagnoses themselves play a role in elevating the risks associated with pregnancies and deliveries, whether or not these women undergo ART. And it's particularly important to realize that a lot of these are pregnancy-associated issues, which in and of themselves can affect the outcome for the offspring. And it's therefore our contention that these factors must be considered in understanding the underlying causes of adverse outcomes of ART. So we also think that not only should a subfertile group be looked at, but we have to actually get into what that subfertile group is composed of, because differing diagnoses within the subfertile group may have differing effects on outcome. In summary, therefore, we can say that ART is associated with low birth weight, shortened gestation, some small for gestational age and large for gestational age babies, as well as small increases in rates of congenital abnormalities. IVF itself, ICSI, frozen embryo transfer, and number of embryos transferred, even in singleton pregnancies, may have an influence on these adverse outcomes. And underlying subfertility, as well as specific infertility-related diagnoses, appear to directly contribute to these adverse outcomes and should be considered as we move forward with studies of ART outcome. Clinical implications of these data include that informed consent for ART should take into consideration the possible adverse outcomes, and specific consideration should be given to the procedures that each patient undergoes and how those may affect her specific outcomes. Further, specifically for patients with diagnosed infertility in certain categories, estimation of risks and management of the pregnancy should include consideration of the risks specific to that diagnosis. Thank you for your attention. The information on what to do if you have questions will again follow this webinar.